Some people think this is the drug that rescued millions of lives from heroin. Doctors called it a miracle. Governments built entire treatment systems around it, and to this day, roughly 1 million people worldwide take a daily dose of it just to stay alive and stable. But this same drug, sitting quietly in orange bottles inside clinics and pharmacies, has now reached a point where its overdose death rate has crept past the very drug it was built to replace. It does not look like a dangerous drug. It is not smuggled in backpacks or cooked up in makeshift labs. It comes from a licensed pharmacy in a small dose prescribed by an actual doctor. And that is exactly what makes it so easy to underestimate. Why would a medicine designed to save addicts from dying end up killing people at a higher rate than heroin itself? To understand that, we have to go back almost 90 years to a laboratory in Germany, long before anyone called it methadone at all, back to two chemists who were not trying to invent a miracle or a killer, just a cheaper way to relieve pain. The story begins in the late 1920s, inside the research labs of Hoechst, a chemical company that was part of the massive German conglomerate IG Farben. Hoechst chemists had spent decades chasing new synthetic painkillers, building on earlier discoveries dating back to the 1880s. In 1937, two of their researchers, Otto Eisleb and O. Schoemann, found an effective synthetic opioid they numbered Compound 8909 and eventually launched under the name Dolentin. That success pushed two of their colleagues, Max Bockmull and Gustav Erhardt, to keep experimenting with similar chemical structures, searching for something that could match morphine's pain relief without needing raw opium, which Germany could not always guarantee in wartime. Over the winter of 1937 into 1938, Bockmull and Erhardt synthesized more than 300 compounds built around a chemical backbone called diphenylmethane. Late in 1939, they landed on one particular compound and gave it a bland internal code name, VA-10820, later shortened to Hoechst 10820. Colleagues nicknamed it polamidon. A patent application was formally filed on September 11, 1941, crediting Bockmull and Erhardt with the discovery. For decades afterward, a persistent legend attached itself to this drug. The story claimed that Adolf Hitler personally ordered its creation to solve Germany's opium shortage, and that the drug's later American name, Dolophine, was secretly a tribute to Hitler himself, sometimes rendered as Adolophine before the letter A was quietly dropped after the war. It is a dramatic story. It is also false. Drug historians who have gone through the original German patent records and laboratory notes found no evidence that Hitler ordered the research or that Nazi leadership had any direct hand in it. The name Dolophine was not even created in Germany. It was coined years later in the United States by the pharmaceutical company Eli Lilly, most likely built from the French words douleur, meaning pain, and fin, meaning end, pain's end. Not a tribute to a dictator, but a marketing name dreamed up by American executives after the war was already over. What actually happened to this German compound is almost stranger than the myth. When the Allies defeated Germany in 1945, they did not just occupy territory, they seized intellectual property. Patents, formulas, and industrial secrets developed by German companies during the war became part of the spoils, distributed among the victorious nations as a form of reparations. Hoechst 10820 was one of thousands of German patents the United States government claimed the rights to. American chemists studied it, renamed it methadone, and handed it to pharmaceutical companies to bring to market. Eli Lilly began clinical trials in 1947 and released it under the trade name Dolophine, marketed simply as a painkiller, a rival to morphine that supposedly carried less risk of addiction. That claim, that it was safer and less addictive than morphine, would later prove to be one of the most consequential misunderstandings in the history of medicine. The drug's second life began almost by accident. That same year, 1947, an American physician named Harris Isbell observed that methadone could ease the brutal withdrawal symptoms of heroin addiction better than most other available options at the time. It became a useful tool for detoxification, given to addicts for a short period to soften the transition off heroin before being stopped entirely. For nearly 2 decades, it stayed in that narrow role, a short-term bridge drug, nothing more. Everything changed at Rockefeller University in New York City in the early 1960s. Dr. Vincent Dole, an internist who had spent years studying metabolism and obesity, teamed up with psychiatrist Marie Neiswander and a young researcher named Mary Jean Creek to try something radical. Instead of using methadone for a few days of detox, what if patients took it every single day indefinitely as a stable daily dose? Their theory was that long-term heroin addiction changed the body's chemistry so profoundly that some people needed a steady, long-acting opioid just to function normally, similar to the way a diabetic needs daily insulin. In early 1964, the team began working directly with heroin-dependent patients at Rockefeller Hospital. Within about 6 months, they had convincing early results. Patients who were once desperate, crime-driven addicts were going back to work, reconnecting with families, and staying out of the criminal justice system, all while functioning normally on a controlled daily dose of methadone that blocked heroin cravings and prevented withdrawal without producing a heroin-like high. Dole and Neiswander published their landmark findings in the Journal of the American Medical Association in 1965, the same year the two of them married. The entire framework of addiction treatment in America began to shift from a moral failing to be punished toward a chronic medical condition that could be managed with medicine. A third member of that Rockefeller team deserves more credit than history usually gives her. Mary Jean Creek, still in her 20s at the time, developed the first reliable laboratory technique for measuring methadone levels in blood and other body fluids. Her work is what actually proved in hard data that methadone behaved completely differently from morphine or heroin once inside the human body, building up slowly, clearing slowly, and settling into a steady state that could suppress cravings for a full day without producing a repeated high. That discovery became the scientific foundation for daily dosing, and decades later it would also become the scientific explanation for why the drug could turn deadly in careless hands. The idea spread fast, though not without resistance. In 1968, fewer than 400 patients nationwide were enrolled in methadone maintenance programs. By January of 1973, that number had exploded to roughly 73,000 patients across the country, and federal regulators formally recognized methadone maintenance as a legitimate long-term pharmacotherapy for opioid addiction. Clinics opened in nearly every major American city, often facing fierce opposition from neighbors who did not want a facility treating heroin addicts anywhere near their homes. Patients themselves sometimes describe the daily requirement to show up at a clinic for a supervised dose as trading one form of dependency for another, a sentiment that gave methadone maintenance an uneasy nickname in some communities, liquid handcuffs, even as the clinical evidence kept showing it saved lives, cut crime rates among enrolled patients, and reduced the spread of bloodborne diseases linked to shared needles. By the time the dust settled, methadone maintenance had become the backbone of addiction medicine, not just in America, but eventually in dozens of countries around the world. The World Health Organization eventually listed it among the essential medicines every health system should have access to, and by the 2000s, international guidelines were recommending methadone or similar opioid agonist treatment as a first-line option for people struggling with opioid dependence. A remarkable turnaround for a drug that started life as a wartime chemical company's patent filing. But here is where the story turns dark. Starting in the 1990s, doctors began prescribing methadone for an entirely different purpose, ordinary, chronic pain, unrelated to addiction. It was cheap. It lasted a long time. Insurance companies and state Medicaid programs loved it because it cost a fraction of newer branded painkillers, and it landed on preferred drug lists across the country. As physicians searched for alternatives to increasingly controversial drugs like OxyContin, methadone looked like a safer, old-fashioned option, something with decades of use behind it. Prescriptions for pain climbed steadily through the late 1990s and into the 2000s, and that is exactly when the death toll started climbing with it. To understand why methadone turned so lethal, you need to understand something almost nobody explains to patients clearly: the difference between how long a drug relieves pain and how long it actually stays active in the body. Most opioids used for pain need to be taken every few hours because their pain-relieving effect fades quickly. Methadone's pain relief also fades within a matter of hours, which tempts patients and even some doctors into taking it more frequently, almost like a short-acting painkiller. But the drug itself does not leave the body nearly that fast. Depending on a person's liver enzymes, age, and other medications, it can take several days for methadone to reach a stable level in the bloodstream, and it lingers there far longer than most people assume. That mismatch is the trap. Someone can feel like the pain relief has worn off and take another dose, and then another, while the drug is quietly stacking up inside their system faster than their body can clear it. Eventually, that buildup can slow breathing to a dangerously low rate, sometimes fatally, often hours after the person has gone to sleep feeling completely fine. On top of that, methadone has a second hidden danger. It can interfere with the heart's electrical rhythm, a condition called QT prolongation, which in some cases triggers a dangerous and sometimes fatal arrhythmia. Combine methadone with alcohol, sedatives, or other depressant medications, and the risk multiplies sharply, which is why health officials have long warned that the margin between a carefully managed dose and a dangerous one is thinner with methadone than with most other opioids. Health officials also noted something that surprised the public at the time. Most of the people dying were not heroin users at all. They were ordinary pain patients, often with no history of addiction, no tolerance built up from years of opioid use, simply following a prescription that behaved very differently in their body than they or their doctor expected. Government investigators later dug into individual state records to figure out exactly where the fatal doses came from. In one Kentucky review covering the early 2000s, researchers found that nearly half of the people who died with methadone in their system had a legitimate physician's prescription for it. About a fifth obtained it through clearly illicit means, and only about 1 in 10 had been receiving it through a supervised addiction treatment clinic. Roughly 90% of all methadone distributed in the United States still flows through those tightly regulated addiction treatment programs, with the remaining tenth going out through ordinary pharmacies for pain, yet it is that smaller, far less supervised slice of the supply that keeps showing up again and again in overdose investigations. Please comment down below and let me know where you are watching this from. I always love seeing how far these stories travel. The numbers that emerged from this shift were staggering. In 1999, methadone was linked to roughly 784 overdose deaths in the United States. By 2010, that number had climbed to about 4,577, nearly a six-fold increase in about a decade, and total opioid deaths that year passed 16,000. The peak came around 2007, when methadone prescribing for pain was at its height. A 2012 report from the Centers for Disease Control and Prevention delivered the statistic that defined this entire era of the drug's history. Methadone accounted for only about 2% of all opioid painkiller prescriptions written in the United States. Yet it was involved in nearly 1/3 of all prescription painkiller overdose deaths, roughly 5,000 deaths a year at that point. Roughly 4 out of every 10 overdose deaths involving a single prescription opioid involved methadone alone, twice the rate of any other individual painkiller. The CDC urged doctors to screen patients carefully. Avoid methadone as a first choice for everyday pain. Use prescription monitoring programs and educate patients on the risks. In 2008, the Drug Enforcement Administration also pushed manufacturers to restrict the largest tablet strength, a formulation never approved for pain treatment in the first place, limiting its distribution mainly to licensed addiction treatment programs and hospitals rather than general pharmacies. So how does this drug compare to heroin specifically? The comparison at the heart of this story. For most of the fentanyl era, heroin overdose deaths in America vastly outnumbered methadone deaths. Because heroin use was widespread and illegally manufactured fentanyl was increasingly mixed into the heroin supply, driving death tolls into the tens of thousands annually at the epidemic's worst points. But something remarkable has happened in the most recent data. As illegally manufactured fentanyl has almost completely replaced heroin on the street, actual heroin use and heroin-involved deaths have collapsed. In 2024, the United States recorded roughly 2,743 heroin-involved overdose deaths, a death rate of about 0.8 per 100,000 people. Methadone, meanwhile, though its numbers have also declined from their 2007 peak, still carried a death rate of about 0.9 per 100,000 people that same year, having fallen only about 10% from the year before. For the first time in a long time, methadone's overdose death rate has actually crept above heroin's. Heroin, once the most feared word in the addiction crisis, has been pushed aside by newer synthetic threats, while methadone, sitting quietly in pharmacies and clinics, keeps its steady, largely unnoticed death count going. That is the uncomfortable paradox sitting at the center of this drug's history. Methadone is not a street drug cooked in a hidden lab. It is not smuggled across borders the way heroin or illicit fentanyl are. It is manufactured legally, prescribed by licensed doctors, dispensed by pharmacists, and administered every single day inside clinics to people trying to rebuild their lives after addiction. And yet its particular chemistry, the long, unpredictable half-life, the thin margin between a therapeutic dose and a dangerous one, the way it interacts with the heart and with other common medications, makes it one of the most quietly dangerous drugs a person can be legally prescribed. Major medical organizations, including the FDA and the American Academy of Pain Medicine, have specifically warned against using methadone as a routine, first-line treatment for everyday chronic pain, a warning that took years of rising death counts to arrive at. At the same time, inside the addiction treatment world, methadone remains something close to a gold standard. As of the middle of 2023, more than 2,000 licensed opioid treatment programs across the United States were serving over 650,000 patients with it. And that network remains the only legal setting, outside of hospitals and a few special cases, where methadone can be dispensed for addiction treatment. During the COVID-19 pandemic, regulators loosened long-standing rules that had forced patients to show up at a clinic every single day for a supervised dose, allowing stable patients to take home up to 28 days of medication at once, and less stable patients up to 14. Studies afterward found this flexibility did not cause the surge in diversion or overdoses that some officials had feared. In April of 2024, federal regulators made those pandemic-era flexibilities permanent, the first major overhaul of opioid treatment program rules in more than 20 years, also expanding the use of telehealth so some patients could begin treatment without an in-person exam. Even that supervised system looks unusual compared to the rest of the world. In the United States, methadone for addiction treatment can only be dispensed through roughly 2,100 federally regulated opioid treatment programs. meaning patients often have to travel long distances every single day, especially in rural areas. Australia, Canada, and the United Kingdom take a different approach entirely, allowing regular community pharmacies to dispense methadone for addiction treatment once a doctor has prescribed it, a model Australia has used since 1985. Researchers who studied Scotland and England after those countries introduced supervised pharmacy dosing found substantial declines in methadone-related overdose deaths afterward. It is one more twist in this drug's story. The country that invented the modern methadone maintenance model, in some ways, still runs it in a more restrictive and less convenient way than many of the countries that copied it. So the same drug that stabilizes a recovering addict under careful clinical supervision can, in a slightly different context, with a slightly different prescribing pattern, become one of the deadliest opioids in the entire pharmacy. Researchers have also directly tested the fear that drove much of the restrictive policy in the first place, the idea that giving patients more take-home doses would flood the streets with diverted methadone and drive overdoses higher. Multiple studies conducted after the COVID-19 exemptions and after the 2024 rule change found no meaningful link between expanded take-home access and rising methadone deaths. Diversion, when it happened, was more often driven by patients who could not physically get to a clinic every single day, sharing or selling a portion of their own dose informally, than by any large-scale black market. It is a detail that complicates the simple story people want to tell about this drug, that easier access automatically means more death. The data, so far, has not supported that fear. Nearly 90 years after two German chemists synthesized a compound they simply called hoaxed 10820, methadone still occupies this strange double identity. It is a treatment that keeps roughly 1 million people worldwide alive and functioning today, out of prison, off heroin, and reconnected with the lives addiction once took from them. It is also a substance that, prescribed carelessly, diverted casually, or combined with the wrong medications, has killed people at a rate that now edges out heroin itself. The myth about its Nazi origins turned out to be false. The reality of its danger did not need a myth at all. It was built into the chemistry from the very beginning, a slow, patient, accumulating danger, buried inside a drug everyone assumed they already understood. Two German chemists working under wartime pressure never set out to create either outcome. They were not trying to build a miracle or a killer. They were trying to build a painkiller that did not depend on imported opium. Nearly a century later, the compound they filed a patent for in 1941 is still doing exactly what they designed it to do, relieving pain and suppressing withdrawal, longer and steadier than almost anything else available. The tragedy is that the same steadiness that makes it so effective in a controlled clinical setting is precisely what makes it so unforgiving the moment that control slips even slightly. A drug that saves 1 million lives a year and a drug that now kills at a higher rate than heroin turn out, in the end, to be exactly the same drug, just handled two very different ways.